Good morning, everyone. Welcome to the American Academy of Emergency Medicine Ethics Committee podcast, Critical Choices, where we delve into the unique ethical challenges in the fast-paced world of emergency medicine. Today, we have with me two military members, and I would like to ask you all to introduce yourselves and tell us about your background and what we're going to be talking about today.
Thanks, Lisa. Hey, my name is Wes Moldogo. I'm a chaplain in the Oregon Army National Guard, currently deployed forward to Eastern Europe in that Balkan area. On the civilian side, I'm also a clinical chaplain at the Hillsborough Medical Center, OHSU, and I'm joined today by my colleague.
I'm Chris Kaufman. I'm a PA with a doctorate in medical science, and I also am in the same place where Chaplain Moldogo is. I am the medical provider for the Maneuver Battalion to the 160.
Well, I'm sure you two have a unique perspective to share with us. You mentioned you had some thoughts that you wanted to share. Why don't you tell us a little bit about what you're thinking?
Thanks for inviting us on this podcast. The topic we wanted to sort of mulling over, and you were shooting ideas back and forth. It's ethics, in fast-paced environments. And in this podcast, we think of critical care and emergency medicine and dilemmas that usually or may come up in that kind of touch points. And knowing your role, as a professor, at a university, things you and your students bring up scenarios. And with us being in the military, as we look at World War, examples of war and triaging, this is a hot topic issue. It's something we reflect and talk about quite frequently. And so I'll throw that back out there. Yeah, it's something.
Yes, and I always forget the part where I introduce myself. I'm Melissa Myers. I'm a professor of military and emergency medicine. Give me an example of one of the ethical dilemmas that you guys are thinking about.
Yeah, I'll shoot it out there. So both me, I call him Captain. His name's Chris. I remember Chris was saying he was a nurse in the emergency department in Portland, Oregon. Frequently enough, we have a large demographic of homeless or houseless people. And hey, Chris, you explain it so much better.
So in my background, I've been in military medicine since '09 as combat medic, but the National Guard provides us a unique background of having that double life. And then civilian side, I've been anywhere from, as far as the medical side, a lab tech and a CNA, and then becoming an ambulance, and then also as a PA now for urgent care and ER. And then some of the time, as Wes mentioned, I did spend some time at a trauma hospital, which is located right across the street from one of the well-known homeless camps that are there. When Wes was breaking up the idea of ethical dilemmas, one of the first stories that comes to my mind, one that's referenced by other providers during training, is when you've got, let's say, what we may refer to as a frequent flyer, right? Someone who comes in pretty often, they're usually just looking to get out of the elements or something like that. But the way that, this department knew that from their experience, from the nurses seeing them, from the other providers seeing them, was that his story never really added up, and then was picking and choosing interventions to accept or not, and then was always not finding any way to not leave until the morning and after, having a meal, a blanket, and a rest and things like that, which in and of itself doesn't seem too bad. If that's the treatment is, a blanket and a place to sleep, that doesn't seem too bad. This place is also pretty busy, and their patient load, depending on the season, can be pretty high. One of the dilemmas that they pose is, would this person still be okay even if we didn't use the room with them? And then what is that taking away from the other patients who came in with, severe lacerations or other kind of injuries, and the time it takes to get to those people and whatever morbidities might come across that? And then not only that, sometimes there's whether it's their manufactured story or whether it's some kind of, drug-induced situation where the history that they're presenting, for example, one of these people, one of the quote-unquote fun stories that would always be told is this guy would come in and he'd say, "Doc, I need you to get this radio out of my nose. They stuffed the radio out of my nose. I need you to get the radio out of my nose," right? And the chances are low, but never zero, that someone put a radio in this person's nose. How far do we investigate this possible foreign object inside the nose? Is it likely that it's a radio? Probably not. Is it likely that there is something in there? Based off of their background, it's definitely possible that something might be there. If this person came in with the same story before and had a previous CT just a week ago, and now they're coming in using the same story, how likely is it? But then you're also still compelled to provide that exquisite care where you can. And then at the same time, you have to balance a triage. If you've got three other things, do you make them wait when this person possibly has something in this nose? And could that be an immediate threat? A lot of the times, what it boils down to whenever we have the discussion and it's brought up in the learning setting, it boils down to what your resources are. And like going back to triaging where you can make the most for the most people. And then you try and capture everyone. And usually that resource that elevates what level of care you can provide everybody, it ends up usually being the effort, the energy, emotional and physical energy that the providers, the nurses and the techs and the medical providers are able to muster to go and accomplish all the tasks, because nothing happens without hands and feet moving. So
I think any emergency physician is going to be familiar with that calculation of I have limited resources and more patients really than resources, with my time and energy being one of those resources. But you don't want to miss something, right? That takes me back to residency. We had a similar patient. She would drive drunk all the time. She unfortunately had alcoholism. But every time she got caught driving drunk, she would say she had chest pain, so they would take her to the ER and not to jail. She pulled this one time, and I was an intern. I was in my first year of medical training, and I had already seen this woman probably 5 or 6 times, and I did not take her seriously. I should have, because when I went to see her, maybe 10, 15 minutes after arrival, I was like, why is her heart rate 140? That seems unusual. We're doing the same chest pain workup we would usually do, and her chest x-ray shows air into the diaphragm, and we find out that she got a GI scope the day before and had a gastric perforation. I have never forgotten that, because it reminds me that you have to approach even patients that are coming back frequently with the same complaints with fresh eyes each time, because you never know which time something's actually going on. But you brought up an interesting point about triage. I know in the emergency department and in the military, you guys probably think about triage a lot. Can you kind of give me your thoughts on how we can ethically approach triage in these resource-limited settings where we know that we can't give every patient the care we would normally give them?
Well, do you mind if I just I'll throw out some advice? There was a specific scenario, and Captain Kaufman, or I should say Chris, and you, Lisa, would probably know better, but it just struck me so much to hear, provider at one point make the remark, you have to select and triage the person and put in priority that has the most likelihood of surviving. And that really struck me, because that person could be someone of perhaps another nationality. When I say nationality, I'm talking about another military and not necessarily our military. And I'm thinking of people that might be 2 or 3 parties down, like a commander or a key leader in that unit's military, where it's like, oh my gosh, that person is a game-changing X factor in the tide of battle and operation, but we're going to prioritize that health because this person has a more likelihood of surviving. And I always thought that is a very significant way to triage. I'm not saying it's good or bad, but it's something I know would turn a couple of heads with people I serve with. But I just throw that out there. That is an interesting way to triage. And on the civilian side, I would assume it's very much similar. I'd say it is similar, if not the same.
So it sounds like you're
yeah, definitely. Depending on the setting that you're in, the quality that you're able to give something in order to categorize its worth is different. For example, in the military, you can say that this person is worth more resources because of what they can bring. In the civilian side, we see that high profile celebrities or leaders are often given quite a bit of attention, as more than you would probably argue that some nameless person off the street might get. Even on a bias level, you can't get away from having to use bias to create quality where there is no quantifiable way to decide which one may be worth more than the other. A lot of times the technique is to use what injury profile will survive or not. And then that can be very difficult, especially for people who aren't as practiced with it. And then especially people looking from the outside, seeing how you have to choose someone else versus the other based off of injury profiles versus who they would believe was more important or worthy. For example, in our Western culture, women and children first is kind of a general sort of accepted tier list of who to take care of first, but they may not be the right candidates when you have a mass casualty event or something like that. That can be really tough because we're all still the same people that get to look at from the outside, even when we're the providers conducting the care or the leaders making the decisions. So that can be definitely very difficult as well.
All right, you guys just brought up 4 or 5 really interesting points. So, Chaplain Montaga, it sounds like what you're talking about is potentially in kind of a deployed setting, you might have a key leader who potentially has less severe injuries, but the loss of that key leader would lead to such significant damage and loss of life that you would triage that person higher. Is that what you were getting at?
Yeah, and that is a big if, right? I mean, who knows if that person actually will, right? But, it's those kinds of questions where I could genuinely see a provider and medics on the battlefield be like, oh my gosh, I got to make this call. And all the moral that follows afterwards, assuming that they believe it's the right call at the end of the day and make that good outcome.
That's very interesting. In an American emergency department, we are not necessarily taking into account what someone does for a living outside of the department. We're triaging more based on injury patterns or potential severity of illness. And then, Chaplain, I did just want to clarify, the American Academy of Emergency Medicine, our stance is that we don't say provider instead of physician. However, you are most likely referring to physician's assistants and battlefield medics when you use the word provider, correct?
Yes, please forgive him.
And we all know that physician's assistants and medics are probably the ones making these hard triage choices in any kind of military setting. Captain Kaufman, I wanted to come back to something that you mentioned. You brought up, and this is absolutely true, that a celebrity would be triaged higher and might receive quicker service in the emergency department. I think that you're right. I think that we've all seen that happen. But it probably shouldn't be happening if we really look at the ethics of it. It's hard to say that someone being a celebrity makes their intrinsic value higher than the unhoused person that you brought up earlier as your example. But I think you're correct. We have internal biases, and sometimes those come out in our triage protocols. What do you think we could potentially do about our implicit bias when we approach triage?
Well, I'd probably say at baseline, I think there should be a standard across the board. I know in medical school most people, they learn about those 4 pillars of ethics, right? Do no harm for the best interest of others, honoring someone's autonomy and the justice, the equality of it, the equity of it, right? So going back to all these examples we put out, the homeless person is not getting equal justice when we don't take their complaints seriously. Their autonomy is damaged or not respected when we don't take their complaints seriously. Kind of fills in the blanks by itself there. I think having a common standard across the board would be the best thing. But going back to when I look as a chaplain, I deal with religious stuff all the time. The interpretation of things can be very different. And I think this is where a lot of the disagreement happens. I met you in an ethics program where this is the thing. And this is why we have ethics committees and ethics consults. And in the medical setting, my hope is generally, I hope someone recognizes that key indicator, red flag that would lead to an ethics consult to begin with. I know in critical care, it's too fast paced often to have an ethics consult, but you'd be surprised at how much the ethics consult committee at my hospital will come together pretty fast if needed, right? But it's just making sure you give that a second glance at least. Do that person the honor when you make hard decisions. And that's more in the civilian setting. In the military, I don't have a great answer for that yet. I hope something parses that soon. But ethics, it is a big role in how you distinguish these triage situations.
Yeah, definitely. I think it's a move forward with answering the question. The answer for coming up with something is training. The sooner that this topic becomes a regular part of medicine and that ethics is going to be tied into it, and teaching people about those ethical dilemmas, the scenarios they might be in, and what choices will require which thoughts and which consequences we are objectively seeing based off of those, decisions that are made, will help us learn and filter out which decisions are the best and what things to value or not. You would to teach people to be objective, kind of like how you mentioned having fresh eyes every time, right? So being objective and treating every moment and putting it together so that way you can remove as much of that harmful bias as possible. On another perspective, though, you would also still want to advocate for looking at a whole picture and a whole patient, the whole situation. Nothing is as isolated as we would like it to be. Nothing is just a 1-paragraph case study. And there are other factors to consider. In the military, for this scenario that we presented earlier, it's a little more simplified. The military has a generally same direction, mission first. If it supports that mission, then that's an easy defendable action, right? In the civilian side, it's a little trickier. In your decision making, you have to at least defend why. So if we chose not to utilize resources on this person, it would have to be objectively because they didn't have these signs or symptoms and have been with no valuable information. So we felt like it would be not a good use of resources, which kind of brings us to the third somewhat unfortunate perspective. It comes down to legality sometimes. And the CYA is like, which decision can you write up that defends you legally, which is within regulations on the military side, and which decisions are within policy on the civilian side, right? And which things inside the standard of care and stuff like that. So I think talking about the ethics as early as possible in people's careers is remind them. And then also on a functional level, wherever people land on working, understanding what are the parameters of your decision-making process, how much is actually up to your interpretation and how much has already been decided for you.
Yeah, I mean, you're making some really great points. And I think to your point about learning ethics early in your career, it's so easy to get this wrong, even with the best of intentions. I remember during the COVID pandemic, we had an initial protocol for ventilator use in the area that I was working. We were anticipating at some point not having enough ventilators. The initial protocol that was drawn out, as a bunch of critical care and ER docs, it was essentially based on comorbidities. The idea was the fewer comorbidities you have, the more likely you are to benefit from being intubated, come off the ventilator, and have a good prognosis. The problem was that at some point, an ethics committee got a hold of this and realized that if we did that, all of the vents were going to go to the rich white part of town because the people there, by and large, had fewer comorbidities. Wes, you kind of brought up some issues of justice earlier. They had to go back to the drawing board on this protocol and say, okay, with the best of intentions, we were trying to get good prognoses, but we have not distributed our resources well. And so the end result was a combination of the two, where certain numbers of vents were allocated by zip code. Within that zip code, decisions were made based on comorbidities in an effort to combine both a just and kind of a utilitarian approach. But it really brought home to me how easy it is to commit this ethical error with, again, the best of intentions and all of the medical evidence in the world at your back justifying that decision.
Yeah. And then just to play devil's advocate a bit, right? If we flipped that the other way, if we were to make an argument that in trying to be equal, did we save less people by putting people on vents that, like we said, the data, the medical perspective thought the other way would be more useful. And that's another ethical dilemma. Which side then do you choose? Do you go with what the mathematical numbers say that, the most events will work on the people that least comorbidities, or do you then broaden that scope out to also include other things? That means we've got whole zip codes that might not get taken care of. And then do we raise the value on that as a factor also? So those are all tricky things without easy answers, but I think then that it's also fair to keep that in mind and broaden the definitions and change the values of things of where you're going to, so that way for whoever survives has to deal with the society that's left over, right? The after effect of those decisions may have an overall greater harm. And I think that might be the thought, right? We might be doing greater harm to society, even if we were per person, saving more individuals. So that's a tricky ethical dilemma in and of itself.
Yeah, there's no easy answers there. It comes, I think, in large part down to value. What do we value? Is it just distribution of resources? Is it a purely utilitarian life years after extubation? What do we value as a society? It turned out that the majority of us valued just distribution of resources combined with a practical approach on who to ventilate. Chaplain,
I think
as far as ethics go, that's usually how it goes. You hope, where does the majority gravitate? And that is really what builds the ethics, and everyone comes together to help build the values and create what values you're going to assign each topic or category. I think that's also why starting early is better, because if you only talk about a topic for the first time in your first year of med school, you have nothing to base it on. You will have a tough time adding to the conversation if it's the first time you've thought about an issue.
There's this concept called moral resiliency that I've been thinking about a lot lately. It's the thought that the more times you come back to a subject and think about it and practice it, the better you're likely to do when that event occurs. I was recently teaching a class and we were talking about triage and some other ethical dilemmas. This topic came up, and the thought was, if you are thinking about the ethics of triage for the very first time, when it's all going horribly wrong, like you're the only doc overnight at an ER, there was a mass casualty event, and all of a sudden you're deciding who lives and who dies. There's an old saying that I've always liked: you do not rise to the occasion, you fall to the level of your training. And if you've never trained on how to do this, then you're not going to do it correctly. By thinking about it and practicing and considering, when the time comes, you have in the back of your mind this framework for, how am I going to avoid bias? How am I going to do this in a reasonable manner that I can live with for the rest of my life?
And you brought that up, and probably my chaplain side comes out here. The question I would ask, in light of everything you both talked about just now, is, can you live with the decision you made for the rest of your life? People surviving that you save, arguably, and medically that is, can they live with what decision you've made for the rest of their lives? So whether that be, gosh, now I got no legs. Thanks a lot, doc, because my advanced care plan, no one ever thought about the situation, right? And the doctor that made the wrong call, or whoever on the medical team made that wrong call. I'm using air quotes because that's subjective even then, right? Will they have closure at the end of the day? And to nuance that, the chaplain thing I have for that is, like, I just hope everyone has good intentions and they have a lot of grace for the profession, because everyone in the medical profession, for the most part, has the intention to help people. I may not start that way for some, but overall, the goal is to help someone. And I just hope there's a lot of grace that goes around in that learning. And thank goodness a lot of hospitals are learning environments. And profession is a learning profession.
Yes, like you guys have hammered home, there's no right answers to a lot of this. There are various answers taking into account various values, and we all might have different values. So we have to give each other some grace when it comes to the decisions that we make.
Yeah. And then I think a lot of the scenarios we're talking about is when the provider has to make the call when it's on them. But a lot of the times we have the opportunity to bring in other people, whether you've got an ethics committee or ethics department to kind of ask input for, or hopefully you've got that individual, the patient, and maybe even family members who can all come to a decision. And again, it talks to how we create our ethics of the majority. Where do we all find ourselves gravitating towards? The decision doesn't have to be done alone for anybody. And then everyone can kind of put their piece in where they believe that would be the best. That's usually my favorite position to take, is just as an advisor, and empowering people the knowledge and the chance to make the decision on how they want their care to go. We don't always get that privilege, but in ethical dilemma scenarios, that is my favorite approach: shared decision making between all of the different entities.
Yes, I agree.
Yep.
And I think I'd like to add too, because I know with triage specifically, it's usually an in the moment kind of decision. But there is a way in which the ethics committee could assist, or an ethics consult could assist, before the event happens. There's nothing stopping us from looking around and saying, my department doesn't have a solid triage protocol for a mass casualty event. Maybe let's write one now, when there is time to phone a friend and get that advice from someone with this background, so that we can stick it up on the wall. And when this actually happens, we have that guidance, even if there's not time to call in someone.
Philosophy we talked about is, as early as you can, deal with all the problems you can anticipate and prepare for them, and then practice them. If you practice performing that triage, even if it's just a talk through, will prepare people, infinitely more than just hoping that you're smart enough at the moment to make the right decision, or lucky enough, hopefully.
I think we're coming to the end of our time, so I wanted to ask both of you, do you have any final thoughts you'd like to share on what we've talked about today?
You got anything, Chris?
Covered everything.
It's great being able to have the chance to, dialogue about such an interesting topic. I think we could go on for lots of things, but at the part of it, ethics is the pursuit of making good decisions the right way. I think it's definitely worthwhile to try and find the best way to find those.
Well, thank you so much for coming on the show. Wes, you were about to say something.
I was trying to echo about grace, for self-compassion. You're going to make some mistakes, perhaps decisions you regret as a clinician, but the hope is that makes you a better clinician. At the heart, always trying to do right and honor the patient, the family, those you serve with. So I really want to put that in perspective as people in your class come to really complex situations, it's going to happen. So a lot of grace upon themselves.
Yeah, definitely. And I think since you brought that up, you mentioned that a big part of your audience is the ER student, right? The other piece of giving yourself grace is also owning any of the decisions you make it with confidence, whatever the outcome, learn from it, good or bad, and follow it down that path and don't give up on medicine.
Well, I can't think of a better note to end on. Thank you both for joining me today. I'm your host, Melissa Myers, and this has been Critical Choices from the American Academy of Emergency Medicine Ethics Committee. Thank you.